Thank you all for tuning in and joining us. On today's podcast episode, we will explore the policy funding and leadership decisions shaping the future of health and human services across states and communities. Today's episode focuses on Rural Health Transformation Program, how it works, and what it will take for states to use this funding effectively to strengthen rural health systems. My name is Laura Perez, and I'm a senior consultant with Barry Dunn, who has a background of experience in developmental disabilities as well as rural health. Today, we will meet with Zil Joyce Dixon Romero, who is the Senior State Government Affairs Manager at the National Rural Health Association, a national nonprofit membership organization that consists of a diverse collection of individuals and organizations, all of whom share the common bond and interest in rural health. NRHA works to provide leadership on rural health issues through advocacy, communications, education, and research. In its role, Zil is responsible for analyzing national rural health trends at the state level, identifying model legislation, developing and executing effective strategies to engage with state government officials and stakeholders, and building upon his relationship with state rural health associations to advocate for policies that promote rural health. Zil is passionate about expanding opportunities in rural communities, demonstrating how advocacy can translate from patient care to policy change, and advancing pragmatic solutions grounded in evidence-based best practices. Rural communities continue to face some of the most persistent barriers to healthcare, including behavioral health in the country. This includes long travel distances to services, workforce shortages, limited transportation options, and stigma that can prevent people from seeking care. These challenges are not new, but the scale and urgency are growing. The Rural Health Transformation Program represents a significant federal investment and a real opportunity for states to move beyond short-term fixes and towards durable system-level change. At the same time, the program is complex. States have had to navigate CMS scoring and overt criteria, planning and approval requirements, and evolving expectations around reporting, engagement, and fiscal accountability. In this conversation, we'll start by understanding how CMS evaluated state proposals, how funding was issued, and why many states are still in early stages of spending. We'll then turn to the practical realities executives are managing right now. That is, how to approach spending decisions, what to look for in sub-award contracts, how to meet reporting and engagement expectations, and how to plan for sustainability and key CMS timelines. Finally, we'll look ahead at the initiatives showing the most promise and how states can ensure long-term success. So whether you're overseeing this work at the cabinet level, briefing legislative partners, or guiding implementation across agencies, this episode is designed to provide clarity, context, and practical insights into how states can make the most of Rural Health Transformation Program funding. All right, let's get started. So Zil, to start, if you wouldn't mind, if you can explain to us, how did CMS evaluate and score state applications for Rural Health Transformation Program funding? Can you walk us through this process?
Absolutely. Well, first, let me thank you for the more than generous introduction to both me and the programs that are happening across rural right now. Really appreciate it. For your listeners, I'm Zil. I'm with the National Rural Health Association, as Laura explained. And so in the work that we do, we have been able to engage and continue to work with state and federal partners on how the RHTP, or the Rural Health Transformation Program, is going to be executed and rolled out. So diving into your first question, how did CMS evaluate and score state applications? We need to kind of take a step back and sort of arrive with how RHTP got to where it is. The Rural Health Transformation Program was built upon an HR 1, or more commonly known as the One Big Beautiful Bill. When there was different rescissions that happened in the Medicaid program, there was then a line item to put additional dollars back into rural as a part of a program to help with innovative practices. And so the program came out of this concept or idea that because of the deficits that are happening in rural, we needed to have some sort of program that would be able to help rural communities build up the infrastructure that they have, as well as look to the future of transformational programs. That's our intent of how we got to now. So when we look at how CMS is evaluating or scoring these RHTP funding, it's really important to understand how the buckets of money work. Right. And so there is the $50 billion that goes into this program. Of the $50 billion over a 5-year period, the money is divided half equally and half by a weighted score. So 25 billion over 5 years will be given evenly to the states as long as they applied and maintain compliance with their proposals. And the other 25 billion is based on a scoring factor. This scoring factor is where a lot of people had questions when they talked about variety based on technical factors. CMS created 23 weighted technical factors, and then scores were applied based on what their state's proposals were. So some of those 23 different technical scores were things such as rural population, facilities, state characteristics, state proposed activities, how they would be working with workload funding, as well as talking about state policies. So I'm going to kind of dive into some of these. The first being the rural population. Of this, bucket B, so to speak, on the rural population, the weighted score or technical scores applied, this accounts for about 53% of that. That has to do with workforce funding distributed across the states. This was based in CMS's understanding of published and historical data, number of rural residents in health facilities, states and other state characteristics, as well as a blend of hospitals and other facilities that are disproportionately helping rural communities. Then we turn to the state proposal initiatives. This is what the actual states submitted as a part of their plan, and this has to deal with workload funding and how CMS's review of these initiatives expect these programs in the latter years to do plan development and progress. So what this means is that when CMS is looking at the reviewed categories of what states are proposing, how much of these fundings are going to be implemented over a period of time. Not all of the incentives were underneath this program were going to be taken into account, such as activities that had to do with population health infrastructure, but others that were something that you could tangibly score over time, like health and lifestyle adjustments over a 5-year period, were accounted for in this about third of the technical scoring system. And then finally, there's the state policy actions. This accounted for less than 1/5 of the technical score elements of the 23, but it is based on the distribution of how states have adopted progress or committed to adopting certain policies that were in compliance with HR 1 in a more rapid rate. I know that there's probably going to be a follow-up here about what are some of the examples of these policies that these states are using. So I'm just going to preempt that currently by saying some of these are certificate of needs, workload funding, making it easier for providers to practice in multiple states, as well as expanding or helping folks in what they are considering professional degrees, though we could talk a lot about nursing and practitioners and non-physicians as professionals, and how they are practicing at the top of their scoping license. And then among other factors, 3 measures in state progress in implementing the MAHA agenda, which is a distribution about 6.4% of the weighted technical score. So there's a lot of variety in that technical score, but that's how state applications were scored.
Thank you for that overview. That is very helpful to understand the priorities from CMS as far as it goes with the funding that they're trying to issue out. And speaking of funding, if we can shift gears and discuss the challenges in the funding distribution and possible implementation delays, could you share from your perspective, why some states have not started spending their rural health transformation funding?
Absolutely. So this is a bit of a trickier question, so to speak, because states are all in different places with the funding. So though there was a deadline to apply, which was in the sort of the end of last year, and then technical scores were scored, and then applications were approved, and there was a notice of funding opportunity acceptance on December 29th of last year. States were expected to start spending on January 1st. Obviously, those of us who may have worked in federal grants or have worked at the state level grants know that there takes some time for administrative offices to be propped up. This isn't a knock against the way that the structures are coming out. It just takes time. And so some states were still in negotiations with CMS to ensure that they're in the most compliance with their in particular proposals. Other states are waiting to set up administrative offices underneath the offices of rural health, or the state, whichever governor had appointed which office to oversee the project. And then additionally, there are some states that are in this weird gray area in which there is a separation of powers issue here. So these dollars are federal grant dollars that are being sent directly to a state. But because of the sheer volume of money that is coming down from the federal government, some states need to create an appropriation line item specifically designed for RHTP. We look at a state that did this really effectively in North Dakota when they called a special legislative session just to ensure that the allocations were done properly and ensure a backing of saying, well, we noticed that there were state policy actions that we can comply with. Let's ensure that we get those done, create an appropriations line item, and create an entire special session just for the rural health programs that are going to come out of our HTP. And then we see the counter to this, right? In the state of Idaho, they're still talking pretty extensively about what is going to be the best way to oversee the program. What's the best way for them to put some sort of oversight over the system? And so they aren't spending dollars quite yet because they want to ensure that the appropriation line item is correct and they are really good on the back end of reporting. And so every state's going to have a different approach, and some are going to take a little bit more time than others.
Thank you for that explanation. As executive leaders begin to deploy these fundings, how can executive leaders set effective guardrails for spending these funds while also enabling regional innovation?
Yes, the guardrails question.
Yes.
As states are going to have to look at a lot of different factors, right? Because one of the main fears that a lot of governors expressed when the program came down the pipeline was, well, what happens if we can't meet the deadlines or if certain programs aren't being rolled out fast enough? And CMS informed them that they may ask for some of the dollars back. And that's a real concern for folks. And so as leaders are either looking to apply for subawards or looking for pre-approval on allowable activities in their expense categories, it's really important that states find trusted partners and ensure that those trusted partners are really good at reporting and compliance standards. This is something that we have talked about at NRHA and a lot of other rural organizations have talked about for years. We have been wanting to be able to prove that there are really innovative practices happening in rural, and this is the opportunity to do that. And it's finally here. We're really excited about it, but it's important that states go out and find trusted partners to work with. And so if you're a state governor or someone who is in that sort of executive category when it's coming to selection processes, it's really important to make sure they have all the comprehensive information. I'm going to turn as like an example here to the state of Nevada. Their office that they have set up for the Rural Health Transformation Program has done a really good job in the last couple of weeks in showing a demonstrated model of what your application should look like. And so in one of their budget line items, they already have their request for funding sort of posted online, and it comes with example templates. It comes with example scope of practices. It comes with a budgetary sheet that you can look at. And these are all really amazing things for folks who are applying to have. But on the back end, when you come to reporting to CMS, having that concrete information is really helpful. So that's a little bit what I would say about sort of the governmental engagement with CMS way. If I am a partner who's aiming to secure some of these dollars, it's all going to come down to pre-existing relationships and trust. Now is not the time to start calling every single person you've ever known, because if you are an effective partner and you are trusted in rural communities, you will hopefully be contacted. But on top of that, we got $50 billion. I say we as in the rural community, the royal we, so to speak. And so when we got this money, everyone and their mother came out of the woodwork, suddenly looking to find a way to take a step into these dollars. And so it's really important that as decisions are made, you demonstrate a level of trust with your rural community when applying for these dollars. Because if you don't have trust in rural, it's going to be really hard to effectively implement any program at any given time. And so if I am someone who is in a level of a C-suite or someone who's looking to apply for subawards, really looking to rely on trusted partners, go into coalition building to apply for awards together, look for non-traditional partnerships. And then also looking at payer engagement and underrepresented areas that you may be able to have a niche and be able to leverage that moving forward.
Thank you for that detailed explanation. I think you've answered some of my follow-up questions, which was regarding strategies and criteria, and then also structure. Is there anything else that you would like to share?
We can dive into strategy and criteria. We can dive into that for sure.
All right, let's do it.
I think for some strategy purposes, I think the big thing that I would talk about is if you are a bigger organization, being the anchor institution for partnerships, right? Some of the examples we see is like, take a typical regional hospital or an FQHC or an AHEC or a university. You're going to have a little bit more of a bigger footprint, but you want to be able to provide additional opportunities to, let's say, smaller organizations that are in rural. So we have seen states already put those in their implementation plans. We look at the North Carolina Roots Hub model, or the Oklahoma Rural Collaborative model, or the Rough Riders Network as a way for purchasing power leverage. And these are all really great options where you see an anchor organization being able to have hub and spoke models where they're able to get programs and policies out to folks in rural areas while still being anchored somewhere that's not in an urbanized area, but rather leveraging the rural roots that they have. There's also what I would say is when you say kind of these strategies that folks could take, it's also thinking of non-conventional or non-traditional partners in the healthcare space and bring them into the fold. I talked a little bit about trust earlier. That's something that we see in rural is always a top issue. I trust this person, I trust my doctor, I trust this organization. And a lot of times that comes embedded, whether it be in faith groups, community engagement groups, or other initiatives that have already existed in community, like a food pantry, that may be able to have an opportunity to utilize that. So we look at the way that Arkansas, in their proposal, looked to embed faith community leaders as part of it, one of its initiatives, where several states were leveraging pharmacies, schools, as well as food pantries and fire stations as care delivery areas that they wanted to elevate as a part of a touch point. And so these sort of non-clinical partnerships where trust already exists in rural communities are places that people should continue to think about investment, not just because it's good for RHTP funding, but it's good for the development of a community. And so when we talk more and more about what is an opportunity and what are some of the strategies folks should implement, it's partnering in ways that people aren't thinking about, but also partnering with groups that are doing good work. And I will continue to harp on this point over and over and over again. These dollars are only good if they are going to people who need them and that you have a trust in that community. Because we have seen constant time over and over and over again where dollars are promised to a community and then they under-deliver because it's not brought in by the right organization or the community just doesn't trust what's happening. And so being able to say, no, I'm a trusted group. I'm a community pharmacist. I am an individual in the fire department. I'm a faith leader. I run the FQHC. These are all programs that people can utilize, but also understand as a trust point.
Thank you for that. That was a really thoughtful explanation and really great, really practical strategies for organizations to think about as they're planning. So thank you for that. Now, shifting gears a little bit towards fiscal implications and timelines, can you share with us how can states sustain the programs they are implementing and what are some strategies that they should consider?
Ooh, the fiscal impacts question. So let's talk about what is fiscal impact when it comes to technical assistance dollars, right? When we look at how much money is an influx into rural right now, there is just a lot. It's like there is no other way to say it. There is a lot of money coming down the pipeline. But when folks are talking about technical frameworks that they can look at when it comes to, frankly, just dollar amounts, right? It's going to come down to compliance. Can you comply with the way that the award specifies, as well as, let's say you are an individual who's getting a subaward contract for $500,000 or $1 million or $10 million in a regional award. You're going to have different compliance requirements with your state because your state's going to have those same compliance with CMS. And so it's really important to ensure that you have someone on your staff or team that understands the federal grant process, someone who understands and can fill out simple standard reporting templates, and then someone who understands complex federal reporting templates as they are rolled out. Additionally, the office that CMS has propped up, the Office for Rural Health Transformation, is hiring and is in the process of staffing up 16 regional officers who will be able to help answer technical questions for state offices, as well as partners that are getting subaward grants. Most of these are going to go through that person in your state that is, openly communicating with CMS, but they're going to be there to help your state navigate and guide so that they are not, let's say, flying off the rails when it comes to spending money. Additionally, there's the contracting element, right? Contracts, making sure everything is legal, your capacity building as a subaward is not only competent, but also your components of your subaward contract are doing the actual work they're intended to do. And so there's a lot that you can do with that, but there's also something that folks should be aware of, which is the oversight focus. Most federal grants have a longer timeline. We think about like almost a planning year, an implementation timeline, and then a reporting year. That's not how RHTP is going to work. There's going to be regular check-ins that are consultative and not just oversight focused, right? There's going to be a subawardee grantee relationship. It's going to feel more like a technical assistance partnership, not like an audit. And so program officers who are helping these partners solve these problems are hopefully going to be able to prevent larger compliance issues later to ensure that the state doesn't lose money in year 2, year 3, year 4, year 5.
Great. Out of curiosity, are you aware if there are any resources, any perhaps templates that are out there that states could leverage, or any online resources that they could seek advice from?
So there's a few resources that I would say as we are in this stage, right? So we have already done the year 1 applications are already in. And so states can't really change those now that they have been accepted by CMS, right? Once your negotiation period is over, you have to start spending the dollars for the programs that you've outlined. But CMS has that new regional officer model that will be hopefully rolled out in the next couple of weeks. We do know that they have begun hiring some of those folks, and so they'll be able to help you sort of sooner rather than later. There is also the National Rural Health Association is continuing to track on the initiatives that have been announced and released. And so if you're a state looking into year 2 already, and you want to see what other states are doing and what might work well for your state, NRHA has a lovely resource that has a more detailed explanation of every single state's proposal and the buckets of investment that they're putting them in, as well as the dollar amounts that are going into the states. So that's a really good resource to harp on our own sort of template there. CMS is also continuing to have updates as they come out. And there's a really great digital footprint that CMS is trying to develop now, so that as resources come in, you're able to access them sooner rather than later. These are just some of the things that I can think that some of the more state primary leads would be wanting to look at. But if you're someone who's in a business model or looking to access some of these subawards, trying to connect with other states and other groups that you may be aware of that are also applying for state dollars is really important. If you are seeing that the application for a certain award on, let's say, oral health coverage is going to impact 4 particular states, right? Because 4 states made an explicit bucket of money that is designed for oral health programming, you're going to want to contact other folks in those states so that you are both duplicating the work effectively, but you're not creating additional work beyond what you're applying for. So those are some common, realistic expectations that you should be able to have, but also know that there are resources available both from CMS, private partnership, and if you are in the rural space, you should have also those contacts that you can reach out to.
Awesome. And we'll try to link those on this posting as well for folks to check out. All right. And for the strategies, if you can talk to us about what are the top strategies that states are using to sustain their rural health transformation program initiatives, and what are some areas that states are prioritizing?
Okay, so I'm going to start with the strategies that they're prioritizing and then circle back to ensure that they're having, solvent funding long term. So in the priority areas, there's sort of what we have dubbed the big three, which is workforce pipeline retention, technology modernization and AI, and then hub and spoke regional models. And so those three groups tend to dominate the conversation. Workforce and technology are in nearly every single application that was proposed. When we look at the workforce pipeline and retention, every single state is investing in this. It is a alarming figure that NRHA and many of our partners have been raising for years, that the workforce in rural, most particularly when it comes to healthcare, has been in decline. And not just a slight decline, a rapid decline. Burnout, high costs of loan reimbursements and loan repayments, and little to no grow your own where folks are born in rural, take a residency somewhere in urban and don't want to come back, are all problems that have been facing rural for years. So states have laid out a lot of plans to address these issues. We've seen approaches varying in your grow your own high school programs. And this is where folks have looked at various different data analysis and studies that show about 14 points that you have to access people in their education to encourage them to want to become a physician, and then let alone a physician in their own rural community. That's a lot of contact points. And so folks are going to start doing recruitment and retention models early on in a child's education, working with county health officials and other businesses in the area to start doing some of that recruitment earlier. Secondly, there's some loan repayment options for individuals who want to come back and work in their communities that they were born and raised in, and trying to work with state governments and state legislatures to have loan repayment options specifically for people who work in frontier, rural, or tribal health coverage. There's also graduate medical expansion. So these GME, graduate medical education expansion, trying to get more programs available to folks, as well as more residency slots and more slots available to people who want to practice specifically in rural. There's also some great investments about rural residency tracks. Housing stipends have become a new fun and interesting tool that people are looking at as a way to recruit individuals. I was at a seminar a few weeks ago when folks were trying to do a little bit of recruitment. And one of the things that stuck with me that someone said was, if you're the kind of person that needs to go to Lululemon and Target every single day, rural's probably not the place for you, but I certainly have a housing statement available for folks who want to hike every day and become really engaged with the Chamber of Commerce. And so it's something that we think that a lot of individuals will be recruited and retained to get into the program, or that states can develop out the workforce retention pipeline. Then there's the technology modernization element. This is where nearly every state touches this. A lot of folks talked about AI in their proposal. And so there is EHR updates, there's telehealth expansion, there's health IT expansion and innovation, and of course, the new compliance with AI tools. When we talk about trust across the healthcare sector, and when we talk about trust across rural, technology and AI do not particularly poll very well. It's just not something that tends to have a good polling data. And so some of this is to talk about AI-assisted tools for clinical decision and support and administrative efficiency, but also some states are using it as a way to talk to their constituents about what AI is actually doing in the space and how it might be beneficial. We know some folks are also using the technology modernization for cybersecurity infrastructure. A growing problem in the hospital space has been attacks on hospitals in cybersecurity. And so being able to take this as a cybersecurity investment tool is really going to help save and sustain some rural facilities. And then finally, there is that hub and spoke regional model. Hub and spoke models are not something new to rural. We have seen a lot of programs that have come to help this structural framework uplift purchasing power. States from Alabama and Mississippi all the way to Wyoming and the Northern Plains states have been building regional care models for years, hoping to develop out, such as we talked about earlier, an anchor institution that represents, dozens of facilities so that they can elevate telehealth services, shared regional services, specialty access services, technological innovations, technical support, and then also while keeping folks in those smaller, localized regions and helping elevate the level of care that they're getting. So it's not about one model or various models. It's about being able to leverage multiple models with multiple facilities. And so that's sort of what some states are prioritizing. I don't want to go crazy too deep in the stats and the numbers, but a number of states have also put an emphasis on behavioral health. 31 different states have mentioned oral health. Maternal health coverage is something that is really, really important and that has faced a lot of closures in rural recently. So states have put a lot of emphasis on maternal health services, WIC support, as well as helping with the moms and babies initiatives. In that, it tends to fall under either the MAHA portion of the proposal, or it tends to fall under things that have to do with chronic disease and food insecurity. And so ensuring that food insecure folks are able to access good, healthy foods. And there is a hope that that will also help leverage that into a space in which there is better opportunity access for WIC programs as well. And so there's a lot in that space that's happening. And then kind of bouncing off of that in the chronic disease and food space, I want to just talk about food and nutrition. As this is a big part of the policy environment, food as medicines programs, community prevention, school-based programs, as well as upstream interventions on diabetes, obesity, and cardiovascular disease were something that were mentioned heavily throughout a number of proposals, not just because it was one of the main 5 that CMS told states to emphasize, but because a lot of states had programs ready to go that they were ready to put in the forefront, especially places like Oregon, where there is a food as medicine program at a number of facilities in the state that are helping to elevate the rural profile and health coverage. And I'll wrap up on some of the prioritization with behavioral health and substance abuse integration. Substance abuse disorder and integration programs are not something new to rural, but they're something that have not been constantly underfunded. So some folks in the Appalachian region have put an emphasis on this, as well as looking into full integration into primary care in the behavioral health space, and EMS responses and school setting responses to SUD programs. And so there's a lot in that states are prioritizing.
So what are the top strategies the states are using to sustain their rural health transformation program initiatives?
And see, that is the key to all of this, right? We have states that are looking towards $50 billion over 5 years. Now, don't get me wrong, it is a lot of money, and rural is grateful that we're going to be able to utilize it in such a really robust way. But when you break it down, some states are going to get less than $1 billion over a 5-year window. And so you have to spend really effectively when it comes to mainstream projects. Now, $1 billion is a lot of money. It's a lot of money. There's no way to sugarcoat it. But when you're starting to work with a new workforce, technical innovations, pipeline retention, technology modernization, substance abuse disorder programs, maternal health improvements, oral health capacities, suddenly this becomes a pretty hefty receipt. And so being able to build regional governance early, right? Especially when you're doing hub and spoke models or you're working with regional roundups, you're going to have to make clinical design a priority. And so getting independent organizations to trust one another, making joint decisions, partnering up folks, investing in facilitation, relationship building in year 1 and 2 is going to really help you in years 3, 4, and 5. Payment reform is also going to be something else that's going to be really interesting to see how it develops over the 5 years. There's going to be some sustainability models that some states are going to take, but states don't have the opportunity to say, oh, I'm going to save $30 million out of my program and throw it in the S&P and hope it grows. You have to spend the dollars you're allocated, right? And so ensuring that the payments as they go out are actually going to the proper places are really important. And then pursuing payment reforms in parallel to everything else is going to be crucial. Ensuring that people are getting paid on time, ensuring that the models are being sustainable, is going to become a harsh reality if you aren't able to keep up with compliance, right? If you aren't in compliance, those dollars are going to get rolled back. It's going to become a problem. And then finally, being able to measure what happens in your communities and figuring out what counts, right? Being able to recognize early if a program is not going to be sustainable and it's not going to work long term, saying, okay, we need to carve this out and we need to replace it with something more innovative in year 2, year 3, year 4, year 5. Because at a certain point, it's going to happen. There is the Hunger Games element of this that's going to happen, where your state is not meeting certain compliance records, so another state may want your dollars. I'm not saying this is for sure going to happen, but I know that it's openly being talked about a lot of people, right? I don't want to be the grim reaper of your dollars, but to say, hey, well, I notice X state is not in compliance with X, Y, and Z thing, and they are not going to get their dollars for year 3, year 4, year 5. Those dollars go back into the general fund that other states can apply for those additional dollars. And so if you aren't in compliance, someone else is going to take your money. Someone is ready and willing and behind you to take that money. So when you talk about compliance, it's really, really important that folks are getting in with trusted partners and ensuring that those folks have an understanding of the federal reporting process, because you don't want to be the one that costs your state $20 million over a 5-year window.
Thank you for that. And thank you for your honesty and transparency with that. I think that's very important to understand as states start to navigate this program. As a follow-up to that, I'm curious, what strategies should states prioritize to help ensure long-term success? For example, you spoke about technology modernization, AI. I know in rural communities, that is not something that folks are very much attracted to, or maybe they have some hesitancy in using and adopting technology. There's also, you mentioned behavioral health, there's also stigma that goes into that in rural communities. What are some strategies that states could prioritize to ensure that long-term success and ensure that they are able to keep and retain funding?
Yeah, great question. Well, I'll start with the AI issue, right? I think we need to look at this as if it is a marathon, not a sprint. Because candidly, AI innovation is not something that's going to happen overnight, and it's not something that's going to be trusted overnight. And so states need to resist this temptation to do everything everywhere all at once, even though it feels like you are on a pressure cooking timeline, because frankly, you are. You can't just say we're going to build a data center and it's going to fix all the medical problems. We have heard some pretty outlandish ideas out there about how AI is going to impact healthcare and how it's going to change the world, and it very may well do. But rural's not your test bubble, and it's not going to be your guinea pig for a lot of this, right? So states need to focus on ways that it can tangibly help keep the costs lower for facilities across the country, right? Right now, 50% of all rural hospitals are operating in the red or a month away from insolvency or on the margins, right? Those are alarming statistics. And so if you say, well, an AI innovative model might be able to help you, that's great. But if you don't know how to utilize it, it's only going to make things worse. And it's going to cause, automatic billing. Oh no, what if we are billing people twice? These are the concerns that people have, right? And so from the beginning, programs need to be structured as a time-limited investment and things that can sustain themselves over time, right? And so if an AI model is something that's going to be really innovative tomorrow, but it's not going to be innovative in 5 years, it's probably not the innovative model for you. But if it's an AI model that can help bring down costs today and help elevate the facility later, that's the thing you're looking for. But as we talked about earlier, the underlying issue of trust in rural, you have to be able that you can sell to your patients that there is a human person operating behind all of these things. And so as CMS is looking for sustainable, budget conscious, measurable improvements in rural health, the human and compassionate factors are the things that people are going to prioritize, or at least should. Because if you have 2 proposals on your desk about technological innovations, and you've got one that's an AI firm that may be not as robust in a 5-year window, and you have something that can improve the cybersecurity infrastructure of a facility that's been attacked before, your options become quite clear. And so That's one component. Leading into the sort of second half of your question, though, which is what strategies should states take a look at as they are doing this? The strategies that we highly encourage people to look at, because it will become a measure of success later, is, are you evaluating things on a mechanisms of sustainability? Is this something that will outlast the program? Because $50 billion over 5 years sound great when we're in month 4 of year 1. But when we are in month 11 of year 5, the program that start today want to be able to continue then, right? And so sometimes it has to be selectively budget conscious. It has to be taken into account of how much money your state or your program is willing to spend today, because you know it will innovate 5 years from now. And so I could probably go through a laundry list of things that I have heard are really good concepts and ideas, but those concepts and ideas may not get selected because they aren't budget friendly, or they aren't producing measurable outcomes fast enough. And so making sure that those 3 key components, because CMS will be prioritizing them, sustainability, budget consciousness, and producing measurable improvements, are the things that reviewers should continue to prioritize. And subawardees should continue to think about as they are applying.
Excellent. All right. As we wrap up this conversation, if you had to offer 1 or maybe 2 pieces of advice to states overseeing rural health transformation program today, what would that be? I know
Advice.
it's a tough one.
I know it is a tough one, because advice is a funny thing when it comes to RHTP. I want to make it clear that NRHA does not have an official, end all be all on these things, but we do recommend that states resist doing too much too quickly, right? Understanding that this is going to take some time. And so RHTP is the largest investment in a generation. And so as state agencies are understandably eager to jump on and deploy everything comprehensively and make sure everything is running so quickly as we can right now, because we've been handed this really excellent opportunity, don't overstrain yourself in a way that you're putting out a million different checks to a million different organizations and then undeliver on them and get your funding pulled back later on. That would probably be my top advice. My second would probably be commit really hard to rural. If you're a person who's reviewing subawards, don't think too hard about, oh, this rural community is doing this and this rural community is doing that. Just make sure that you are resisting the temptation to put these dollars through an urbanized area. Because when you visited one rural town, you have visited exactly one rural town. And so building everything in these services can really be a testament to the longevity of governance. And so learn fast, adjust course, and ensure that it's going to the places that the dollars need to be. And then, I don't know, I'll try to save it on a little bit more of an end on a more upbeat and motivational note, which is that rural has been waiting for an opportunity to demonstrate the resiliency and innovations that we have been doing for years. Rural is often the last piece of a conversation when it comes to healthcare, but there are still 62 million Americans that live in a rural area or classify themselves as living in a rural and frontier area. And so that's a lot of people that need medical assistance, technology innovations, facilities to go to, and they've been closed. And so now is the time for you to invest in innovations that are going to cost some money today, but are going to save lives tomorrow. And keeping that as your sort of moniker as you move into the funding allocation time will be so important. Remember rural, and remember about that it's saving lives for tomorrow. And I think that's where we're headed.
With that, thank you so much, Zil, for sitting with us today to share your insights and expertise regarding Rural Health Transformation Program. We truly appreciate it. And thank you to the listeners as well for joining us for this conversation. We We hope it provides useful perspective as you continue the important work of improving rural health access and outcomes in rural health communities. Thank you so much.
Thank you.